Hello, and my name's Phillip Conaghan. I'm an academic rheumatologist from Leeds in the UK, where I run the Arthritis Research Institute at the University of Leeds. And I'm going to chat to you about the future of imaging in psoriatic arthritis. Now, I think the major benefit of modern imaging, and by that I mean MRI and ultrasound, the major benefit remains its ability to detect subclinical disease, or what we could have also called disease you can't find with your fingers. And that's the problem that we have for a lot of peripheral joints. In the spine, we need MRI, and what I'm going to be talking about is largely peripheral joints. So for peripheral joints, we're often inaccurate with what we find for both enthesitis and synovitis, and that's where modern imaging comes in. Now, I do want to stress that I use a lot of imaging in my research and very little imaging in my clinical practice. And I think taking a good history and examination is still critical for us being good clinicians. So what about future imaging for these other modalities? So the impact, I think, is going to be, firstly, in understanding pathogenesis. And when you think about it, we've now got the ability with modern imaging to get better phenotypes. So now we can link our genomic data and all our DNA data to a better phenotype. But unfortunately, at present, I think in PsA studies, there's still a clinical phenotype is used as the gold standard. And I think we can do better, and that may well show us something better from all our wet biomarkers and other things people are exploring. The other exciting thing, I think, for PsA imaging is now understanding preclinical PsA. So in RA, we've had CCP antibodies that we could look at before disease onset. But in PsA, we know there's a whole lot of people with psoriasis who have subclinical enthesitis and synovitis before they develop the clinical disease. So this offers the opportunity for us to do pre-PsA studies, if you like, and intervene before people get psoriatic arthritis. I think that's pretty exciting. And at present, imaging is the best biomarker we've got for detecting a preclinical PsA state. Now, in clinical trials, we're already starting to see the impact of imaging work over the last decade to develop scoring systems to look at as an outcome measurement in clinical trials. And Mikkel Ostergaard's published this year in Rheumatology the SAMRIS, the OMERACT PsA MRI score, showing responsiveness in a large RCT of over a couple of hundred patients. So that's the tools are now getting better for doing semi-quantitative assessment. And as well, the MRI group and Ashish Matthew published this 2 years ago in RMD Open, that we've now got heel enthesitis scoring systems for Achilles tendonitis and plantar fasciitis. And these are difficult things to score. You need optimal images, and we're still going to be developing those. Ultrasounds come a long way in clinical trials. And recently, Maria Antonio D'Agostino has shown some wonderful work from a large trial using ultrasound outcomes for synovitis and enthesitis in a large cohort study. And that was called the Ultimate Study, and that was presented at ACR 21. And there'll be more on that study coming out in EULAR coming out. And what it's showing is that the EULAR OMERACT GLOSS score, which looks at ultrasound synovitis, both grayscale and power Doppler, is responsive to modern biologic therapy. And so we've now got an objective measure, and she's been developing with the OMERACT group different enthesitis scores that can be used practically for trials in multiple center studies. So that's a big step forward for ultrasound in PsA clinical trials. And there's a heap of work to be done for ultrasound and MRI on how many joints should we look at, which ones can be done feasibly in a clinical trial. Remember also in clinical trials that most of the people going in tend to have polyarticular PsA, so they're not always typical of the patients you and I see in clinic who might have an oligoarthritis or even a monoarthritis. I think the other exciting things that comes out of clinical trials work is starting to see that if you want best response, you might want to include people on the basis of imaging detected pathologies. So if you really want to show agent X works better on enthesitis, then you may want to make an inclusion criteria for your study the presence of imaging detected enthesitis at such and such a site or a number of sites. Because remember, that discrepancy between clinical exam, especially for enthesitis, and what imaging shows can be quite a lot. So I think we're going to be using imaging more for inclusion criteria for clinical trials to enrich for things that are likely to respond in the study. Now, what about in clinical practice? Well, to me, ultrasound, which I'm lucky to have access to in clinic, is very useful. And the commonest thing we're trying to always refer is patients who've got long-standing psoriasis, joint pain. Is this PsA or not? Again, history is very important. Examination is very important, but I find sometimes an ultrasound scan in that group of people can be useful. And you're really looking to see how much osteoarthritis change is there, how much tendinitis, peritendinitis, all those sort of other things that we see in psoriasis are there. So I think there's still a big role in that PsA versus osteoarthritis group. We're still not sure whether whole body MRI will come into more routine practice as a screening tool, especially for spinal disease. So I think more work needed there. And I still think that just like in rheumatoid arthritis, beware of what we call the resistant patient who's not responding to therapies, as a quick look at them to see if they've actually got active inflammation there before you start changing DMARDs and escalating therapy. And I'll finish by saying the future of any imaging now is going to involve artificial intelligence and machine learning quantification. So we've got examples in RA and PsA of that quantification happening in image analysis, but now we're starting to move into algorithms incorporating deep learning that will incorporate clinical and imaging findings. So the future is definitely in artificial intelligence. Thanks very much.